Hello all, welcome to Dental Notes and Mnemonics. Today we are going to discuss about Class 1 Malocclusion. So let's begin with the definition first. According to Angle's classification, Class 1 Malocclusion is characterized by normal molar relationship where the mesio-buccal cusp of maxillary first molar occlude with the buccal groove of mandibular first molar. However, despite this normal skeletal and molar relationship, malalignment of individual teeth is present. This may include crowding, spacing, rotations, proclinations, or crossbite. Dewey modified the Class 1 malocclusion definition given by Angles. He described 5 types of Class 1 malocclusion, and type 1 is crowding of anterior teeth, usually the maxillary incisors. In type 2, there is protrusion of maxillary incisor, often with spacing. Type 3 is anterior crossbite, where the maxillary incisors occlude lingual to mandibular incisors. And type 4 is posterior crossbite, which may be unilateral or bilateral. And type 5 is mesial drift of molar due to premature loss of deciduous molar. The essence of this classification is that even with the class 1 molar relationship, different malalignment can occur, which helps in diagnosis and planning the appropriate treatment. Class 1 does not arise from one single cause. It is usually multifactorial, meaning several factors react together to cause a malocclusion. We can divide these into 4 main groups. First is a skeletal factor. In class 1 malocclusion, the skeletal pattern is usually class 1, but it can also be class 2, class 3, with the inclination of the incisor compensating for the underlying skeletal discrepancy. Marked transverse skeletal discrepancies between the arches are more commonly associated with class 2 or class 3 occlusion, but milder transverse discrepancy are often seen in class 1 cases. Increased vertical skeletal proportions and an anterior open bite can also occur. The second is the dental factors, which are the most common one. They include crowding due to lack of space, spacing from missing or the extra teeth, rotations or the tipping of the teeth, and even the conditions like transposition. Premature loss of primary teeth is another important dental factor, as it allows neighboring teeth to drift into the space. Third is the soft tissues, habits. Habits such as thumb sucking, mouth breathing, and tongue thrusting can exert continuous pressure on the teeth, gradually disturbing their alignment. And finally, other causes may include trauma, which may lead to early loss of teeth and drifting, or even iatrogenic reasons like poorly designed restorations or extractions. According to the type of class 1 malocclusion, crowding is the most common presentation. It occurs when there is insufficient arch space for all teeth to erupt properly. Teeth overlap, appear irregular, and may erupt out of alignment. Spacing is opposite of crowding. Here there is an extra space in the arch resulting in visible gaps. Causes are congenital missing teeth, microdontia, or the habits. Proclination or the retroclination, that means the incisors are tipped forward in the proclination, which is common in mouth breathers or tongue thrust. And retrocline incisors are typically backward, often due to lip sucking or arch length issues. Procline incisors are prone to trauma, and retrocline incisors compromise smile aesthetics. A tooth rotates around its long axis is known as rotation. Their examples are rotated premolars in the canines, and they are common in crowding where the eruption path is disturbed. Midline discrepancies, where the upper and the lower dental midlines do not coincide with each other. The causes may be unilateral tooth loss, asymmetric crowding, or skeletal asymmetry. Crossbite is when one or the more teeth occlude abnormally in buccolingual directions. It may be anterior crossbite or posterior crossbite. In case of open bite, anterior teeth fail to overlap vertically, leaving a gap when the posterior teeth are in contact. It may be due to thumb sucking, tongue thrusting, or skeletal vertical excess. Deep bite is due to excessive vertical overlap of incisor, exactly opposite to open bite, and often seen in short Let's go through the clinical features of the class 1, though we have discussed, but let me summarize them. First of all, the molar relation by definition would be class 1, which is normal. The upper first molar mesiobuccal cusp fits into the buccal group of the lower first molar. This tells us that skeletal base is usually normal. So the problem is not the jaw relationship but the positioning of individual teeth. Malalignment can appear as crowding, spacing, rotations, or the crossbite. Clinically, this is what we notice on inspections: irregular dental arches. The arch form may look irregular or asymmetric because of uneven tooth positions. For example, one side may appear crowding, the other may look normal, or midline shift may be visible if the teeth are lost or drifted. There may be the functional problem in case of crossbite or the open bite is present. The patient may have difficulty in mastication. In anterior open bite, as the incisors don't meet, the patient is not able to bite into the food. Diagnosis should always be comprehensive and includes history and the clinical examination. Extraoral, the facial profile, lip incompetence, and habits history should be asked. Intraorally, check for the arch form, crowding, spacing, rotation, overjet, overbite, and midline discrepancies. Radiographic assessment includes an OPG to evaluate presence, absence, or pathology of teeth. Cephalometric analysis to confirm the skeletal base relationship and incisor inclination. Study models are used to assess the arch length or tooth material discrepancy. Coming to the various treatment modalities for class 1. First of all, talking about the interceptive orthodontics for children in mixed dentition. It is the goal of interceptive orthodontics is to prevent worsening of the malocclusion. It is indicated in those cases where the skeletal bases are normal but developing irregularities are seen. For example, we may give space maintainers if the primary tooth is lost prematurely to prevent mesial drift. Space regainers uses a distalizing appliances if the permanent molar has drifted forward. Serial extraction in case of severe tooth arch length discrepancy or in crowding cases. Habit breaking appliances are given for thumb sucking, tongue thrusting, or mouth breathing. The main aim of interceptive orthodontics is to guide eruption, preserve arch integrity, and reduce need for complex treatment later on. Second is the corrective orthodontics in adolescent and adults, where the goal is to align the teeth and establish functional and aesthetic occlusion. The mainstay for corrective orthodontics is fixed mechanotherapy or clear aligners. Require surgical orthodontics in case of class 1, and this is only required if there is skeletal discrepancy masked by dental compensation. For example, in the severe bimaxillary protrusion with normal molar relation. In the management of class 1 malocclusion with crowding, the treatment approach depends largely on the severity of crowding. Crowding and spacing are diagnosed by comparing the arch length available with tooth material required. The arch perimeter is measured along the arch using brass wire or divider, while tooth material is obtained by summing the mesiodistal width of the teeth with a caliper. For mild cases where the space discrepancy is around 3 to 4 mm, non-extraction options are usually sufficient. This include proximal stripping of the teeth, minor arch expansion, or slight proclination of incisors if the patient profile allows. In moderate crowding of 4 to 7 mm, more space is required. This can be achieved by arch expansion using appliances like quad helix or arch wires, or by distalizing molars to gain space in the arch. In some cases, extraction may be considered if expansion alone is insufficient or if facial profile demands improvement. For the cases with the severe crowding exceeding 7 to 8 mm, extraction therapy is always necessary, most commonly of premolars, followed by alignment with fixed orthodontic appliance. Please go through these two tables, the relief of crowding by gaining space, and the next table is 2 factors to consider before extraction for crowding. When it comes to appliance selection, removable appliances such as jack screw plates, canine retractors, or Z-spring are effective for mild and localized cases. especially in anterior region, but they have limited control and rely heavily on patient appliance. Fixed appliances using night-eye arch wires, open coil springs, or full arch mechanics are preferred for moderate to severe crowding as they provide precise control, bodily tooth movement, and complete alignment. The management of class 1 malocclusion with spacing, it requires identifying the cause and eliminating it. It is also very important to prevent the relapse in the case after the treatment is completed. Habits can be managed with habit breaking appliances like cribs or rakes. Cystic lesions or odontomes are treated surgically, while abnormal labial frenum attachments may require frenectomy. Retained deciduous teeth are extracted to allow permanent teeth to erupt. Space closure can be achieved by using removable appliances like labial bows or finger springs, or fixed orthodontic appliances such as e-chains, closed coil springs, elastics, elastic thread. In case of minor spacing, a conservative approach using shade matched composite resin restoration may be sufficient. Two options for the space management. First is space closure or space maintenance for the future prosthetic rehabilitation. Space closure is preferred for small or moderate gaps where the teeth can be moved without affecting midline, profile, or occlusion, improving alignment and aesthetics. Space maintenance is indicated for the larger spaces where the closure could compromise function, symmetry, preserving the site for the prosthetic replacement like implants or bridges. The choice depends upon the space size, occlusion, aesthetics, patient age, and long term stability. So, this was all about the class 1 malocclusion and its various types in the management. Here, I have only discussed the management of class 1 crowding and class 1 spacing. Hopefully, in the next videos, I'll be discussing the management part of the other types of class 1 malocclusion because each type is a topic in itself. So, see you in the next video. Till then, bye bye. Take care. Have a nice day.